Hello everybody, we have talked about antibiotics absorption and distribution in previous videos. This presentation will be talking about step 3 of pharmacokinetic. It is known as metabolism. Most drugs are chemical substances that are not naturally produced by the body. The chemical reaction occurs that can convert these drugs into compounds easier for the body to eliminate. This process is called metabolism. Lipophilic drugs are involved in hepatic metabolism and the metabolites are eliminated via the kidney, while hydrophilic drugs involve minimal hepatic metabolism and usually eliminate unchanged form. The resulting byproducts of metabolism are called metabolites. They can be active, inactive, or toxic. Clarithromycin, erythromycin, metronidazole, and clindamycin are metabolized into active metabolites and they have therapeutic effects even after metabolism. Penicillin, ampicillin, and cephalosporins are metabolized into inactive forms and they do not contribute to the antibacterial action. Some antibiotics are metabolized into toxic forms, causing serious side effects. Metronidazole has an active form, but its toxic metabolites can cause neurotoxic effects. Chloramphenicol's metabolites can lead to bone marrow suppression, while tetracycline's metabolites can result in liver toxicity. First-pass metabolism, also known as a first-pass effect, is a phenomenon in drug metabolism whereby the concentration of a drug is significantly reduced before it reaches systemic circulation. This process occurs primarily in the liver and the intestines. When a drug is taken orally, it is absorbed through the gastrointestinal tract and transported via the portal vein to the liver. The liver metabolizes the drug extensively, often resulting in a substantial reduction of the active drug that enters the bloodstream. This can affect the drug's bioavailability and efficacy. There are 3 phases involved in metabolism. Phase 1 metabolism yields a polar, water-soluble metabolite that is often still active. Many products from this phase can become substrates for phase 2. The most common chemical reaction in phase 1 is oxidation, primarily catalyzed by cytochrome P450 enzymes. These enzymes oxidize antibiotics, forming more hydrophilic metabolites that are easier to excrete. Drugs that interact with cytochrome P450 enzymes can act as inhibitors or inducers, affecting the metabolism of concurrently administered medications. Here is an example of the co-administration of rifampin and warfarin. Rifampin is an enzyme inducer, and therefore can reduce the concentration of warfarin. It requires an increased dose of warfarin or prescribe alternative medication to achieve the therapeutic effects of warfarin. Conversely, when ciprofloxacin is co-administered with warfarin, ciprofloxacin is an enzyme inhibitor that can elevate the levels of warfarin, increasing the risk of bleeding. In such cases, the dose of warfarin may need to be reduced. Phase 2, metabolism, also known as the conjugation phase, involves the addition of endogenous substrates to the antibiotic or its phase 1 metabolite. It involves various chemical reactions depending on the antibiotic. For example, chloramphenicol undergoes glucuronidation, sulfonamides are subjected to sulfation, and penicillins undergo amino acid conjugation. These processes make the molecules more water-soluble, facilitating their excretion via urine or bile. What is metabolic rate? It is the rate at which the body uses energy. It is influenced by various factors. Metabolic rates can vary with age. For instance, neonates and elderly individuals often have a slower metabolism. Genetic variations can affect enzyme activity, leading to differences in how individuals metabolize antibiotics. Impaired liver or kidney function can slow metabolism and excretion, potentially leading to toxicity. Other medications can induce or inhibit metabolic enzymes, altering the metabolism of antibiotics. Therefore, understanding drug metabolism is important in clinical practice. It helps tailor dosages to individual patients, accounting for variations in metabolism rates. This reduces the risk of underdosing or overdosing and improves therapeutic outcomes. It predicts and manages potential side effects and drug interactions. This helps prevent adverse drug reactions and enhances patient safety. We hope you find this presentation helpful. We look forward to seeing you at our next session on drug elimination.